Good evening. My name is Mike Fitzpatrick. I want to thank you for letting me into your home and into your work in order to talk about a topic that I have a particular interest in and hopefully convey some of the thoughts I have about orthobiologics tonight. It's an area that I've had particular interest for the last 15 years. It's really in its infancy. So a lot of the information I'm gathering every week and every month, and the information is changing periodically and changing rapidly. So I'm going to touch on the stuff that I've learned over the last 10 to 15 years. And hopefully this field is going to continue to expand because I think the potential is great. As I mentioned, my name is Michael Fitzpatrick. I'm here in South Orange County at South Orange County Orthopedics in Mission Viejo. And my background is in sports medicine orthopedics. So you understand where we're going to go today. Here's the overview. We're going to first talk about the background of orthobiologics, some definitions that help us get us all talking in the same language, and then the options for the orthobiologic sources. Just briefly, it's really the three that we have time to talk about tonight are PRP, stem cells, and amniotic tissue. And then we're going to open it up at the end for some questions, so I hope I can answer them. If I can't answer them, I don't mind getting people's email address and researching them for you and getting that information back to you. First and foremost, orthopedics, and traditionally, is the prevention and treatment of conditions that affect the musculoskeletal system. Traditionally, that included us mechanically addressing orthopedic problems of the musculoskeletal system. You see here a picture of a hip replacement. Someone has hip arthritis, we put a new hip replacement in. Someone breaks a bone, we put a metal plate on it. Someone has a torn muscle, we repair that ligament. That is traditionally what we have done, and we've gotten pretty good at the mechanical repair of orthopedic conditions. However, there are limitations of that mechanical strength. It's not the limitations of what science and materials have taught us, it's really the limitations of nature. So the people that we are treating have limitations. Healing takes time, and as we age, the ability to heal diminishes. And so we're wondering if the next frontier in orthopedics is not only addressing the mechanical problems, but also trying to address the biologic problems. So can we change the biology of the musculoskeletal system so that we improve our healing rates and improve the biology of aging tissue? And that's where orthobiologics comes in. Orthobiologics, a brief definition, is the biologic material used to improve the healing of broken bones, injured cartilage, injured muscles and tendons, and injured ligaments. Biologic material can come from a number of places. First, it can come from yourself. It can be transferred from one part of your body to another. That is called autologous. Other materials can be transferred from another human being, and that they can be adjusted and implanted or injected into a person, and those are called allogenic. And then the third type are synthetic ones that are produced in the laboratory. Now, because the brief nature of this talk, we're only going to be able to touch on the first two, the autologous and the allogenic. We're going to leave the synthetic because there are not really a lot of current applications to it. We're going to talk about the first two. Orthobiologic materials that I'm going to talk about today, as mentioned, are platelet-rich plasma, stem cells, amniotic tissues, and as I mentioned, synthetics are in that realm, but we're not going to touch on them today. So platelet-rich plasma is our first topic. As you see here, we have a test tube, and this is often how this is prepared. As it is centrifuged, different layers are determined based on their weight, and once you centrifuge them, we can predict which materials are in which layers. The top layer is the plasma. Platelets are also in that top layer, and then as you get to the middle layer are white and red blood cells, and the very bottom are the red blood cells. So platelet-rich plasma is typically autologous, meaning you obtain it from the person that you're going to implant it in. and it contains higher than normal levels of platelets. So we try to, currently the science is telling us that somewhere between the level of 3 times your normal platelet level to 7 times the normal platelet level are what the commercial products provide and what the scientists are testing. Plasma contains some very special products to it, and platelets secrete some powerful growth factors, such as platelet-derived growth factor. These are abbreviations that are maybe somewhat technical, but they are some powerful chemicals within our body that really help aid in healing. There is vascular endothelial growth factor, transforming growth factor beta, epithelial growth factor, and a dozen others that are included in plasma. And they provide benefits for healing and diminishing inflammation. So what is platelet-rich plasma? I like to think of it like everything. There's a yin and a yang. There's a balance in our system. Our blood contains that balance. One part of the balance causes inflammation and breakdown of tissues. So if you have an injury, you go through an inflammatory phase, your body swells. That's what red blood cells do and red blood cells do. The other part of our balance is part of our blood that decreases inflammation and causes growth and healing. And that's where platelets and plasma play the biggest role. So there are different types. I don't want to get too caught up in these technical things, but this will help highlight the fact that why research is getting to be difficult, because different scientists test different type of platelet-rich plasma. Not all platelet-rich plasma is the same. They've tried to categorize different ways of preparing the platelet-rich plasma, and here's a general way that we divide it into 4 different types. Platelet-rich plasma can either have increased in white blood cells, so we include the white blood cells even though they cause inflammation, and activation. What activation means is platelets are meant to clot. So in your bloodstream, and the reason why people take aspirin and such is we want to prevent the blood clotting so that the platelets in the plasma remain liquid. But there are activating factors that we can put into them or include in them that help the blood clot when we do the injection. And then platelets, there's a variety of different type of platelets, and this helps us categorize as if we're trying to unify different researches and compare different research projects, is those that have greater than 5 times the normal level of platelets or less than 5 times the normal level of platelets. Those are A's and B's. Similarly, there are ones that have activated or non-activated. And the type 3 and type 4 have minimal or no white blood cells and are either activated or non-activated. So this is a classification system that is most commonly used today. How do we obtain platelet-rich plasma? Simply, it's just like if you were donating blood or you were getting a blood draw for laboratories. A person will harvest the blood, typically between 15 or 120 cc's of blood. There's a centrifuge and the peripheral blood to concentrate the platelets between 3 and 7. There are many different types of these systems and different number of different companies. The systems that I use, because most patients have a normal level of platelets, and so when you use a very simple centrifuge, you're going to get a good concentration of platelets. There's a subset of people that do not have that, or we think it would be better if we increase the number of white cells or platelets. So there are centrifuges that are much higher tech that we use, and I use those in the office for people that may have low platelets or may have a cancer or may be aging and do not have the proper number of platelets. There are ones, as I mentioned, that have leukocytes, and when I say the word leukocytes, those are white blood cells. So we either call it leukocyte rich or leukocyte poor, meaning they have white cells in them or they don't. And then we re-administer it to the site that is injured. So now we are treating, and quite successfully, osteoarthritis of the knee, the hip, the shoulder, the elbow, and the wrist. We're also doing tendinitises and tendinoses of tennis elbow and golfer's elbow. These are also called medial and lateral epicondylitis, patellar tendinitis, Achilles tendinitis, and rotator cuff tendinitis. Please note that these PRP, we know, does not treat advanced osteoarthritis, so we really know the best type of osteoarthritis that it treats is in the mild to moderate range. So it does not prevent somebody, but it hopefully slows down the process of developing an osteoarthritis. We also treat muscle injury. So if people have muscle pulls, groin pulls, hamstring pulls, quad muscle or gastrocs, which are your calf muscles, get pulled. These are typically occur during explosive type of sports like basketball, like soccer, football, in which you have to go from a stop position to an explosive starting position, to a running position. Osteoarthritis, PRP, when it treats osteoarthritis, stimulates chondrocytes. Chondrocytes are the cells that help produce cartilage in your knee, and they help heal cartilage. Synoviocytes are the lining of your joints, and they help produce lubricants for your knee, which is called synovium. They help downregulate things that cause inflammation. These are stuff like I have in parentheses, interleukin-1. And they're also proteins that our body produces because we have to get rid of bad tissue. So there's degradatory proteins, such as what we call metalloproteases. And they increase production of healing proteins like type 2 collagen and prostaglandins. Also for tendinitis, the effects of this have been an anabolic effect. So you think of steroids can cause one of two things. An anabolic effect, they help build up tissue. So you know bodybuilders have anabolic steroids, but this is anabolic effect really means promotes healing, increases production of proteins. So that's that's what's in PRP, an anabolic effect. It promotes and accelerates healing, increases mRNA. So these are the genetic products of our cells that help cause protein production and help healing. And they help decrease inflammation. Now, as I mentioned before, there are certain researches and certain people believe that you should either use leukocyte-rich or leukocyte-poor, meaning that a few or a low number of white blood cells are included in the platelet-rich plasma. As a general rule of thumb, what most scientists are thinking is that platelet-rich plasma that is leukocyte-poor is best for osteoarthritis because there's a lot of inflammation. We don't want any more inflammation going on in a joint. Whereas if we're treating a tendinitis, that we may use a leukocyte-rich. And now this is a matter of debate because they said with tendinitis and tendinosis, you need a little bit of inflammation in order to help heal the tendon. This is still a matter of debate, however. PRP, it's increasing in the numbers to tell you how important it is the average cost right now for a patient or for an insurer or for somebody who is paying for it is around about $900 versus a cortisone, which is $300. And this typically tells you why oftentimes insurers do not pay for this because they would prefer to pay for cortisone. It's often a financial reason with the idea that and stated that this has not been totally proven to help decrease inflammation and help improve healing. The global market currently has a is increasing, and there's about $500 million of platelet-rich plasma treatments in the United States per year, and the growth is expected to be 12% per year. So these are going to be busy slides, and I don't want to really confuse you with them, but I really want you to understand that so just as to digest some of the important parts of the studies, and there are a lot out there, PRP is a promising treatment. These are generalized studies that help try to bring all the studies together and help kind of have a consensus statement. And in this study, they said that platelet-rich plasma is a promising treatment for some musculoskeletal diseases. However, evidence of the efficacy has been highly variable, depending on the specific indications. Additional high-quality studies are needed for us to really help improve our clinical understanding and give more evidence to our belief that platelet-rich plasma is beneficial to tendinitis and arthritis. Thus far, the evidence appears to suggest that PRP provides some benefit in patients with knee osteoarthritis and lateral epicondylitis. So most of the studies we've done are on osteoarthritis in the knee and tennis elbow. And this is another, what we call a meta-analysis, in which they try to bring together a lot of studies and come down with a consensus statement. And, I apologize on that. In summary, we found that platelet-rich plasma to have variable outcomes, that they cannot always tell whether they treat pathology or not. However, there is a lot of promise for people that are having trouble treating musculoskeletal injuries that it is still a potential benefit. They have not come to a 100% conclusion as of right now. The second topic that I'm going to talk about today are stem cells. So people hear about stem cells, and I really want to make sure people understand the differentiation between platelet-rich plasma, which is not stem cells, and stem cells. People use those terms interchangeably, but they are not the same thing. Platelet-rich plasma is a little bit cheaper and a little bit less expensive to do. Stem cells can be much more expensive. So stem cells, the technical definition is they are undifferentiated cells of a multicellular organism that are capable of giving rise to similar cells of which certain other cells can arise by definition. Now that's kind of confusing. So more simply put, stem cells can turn into other cells of different types, such as muscle cells, cartilage cells, bone cells, nerve cells, etc. And just for thoroughness sake, I want to tell you about the difference between what's called pluripotent stem cells. They are stem cells that come from embryos, that you can take one of those cells, and you may hear of test tube babies or test tube animals. One cell then can turn into the whole living organism, including the liver, the lungs. Those are called pluripotent stem cells. Those are not often used in the clinical setting for a number of reasons, and I'll talk about those. They are embryonic stem cells that are truly taken from a fetus, whether it is an animal or a human. And then there are now this gentleman here, Yamamaka, who recently, I would say recently within the last 10 years, has been able to take a regular cell from the skin of an animal and reverse it and turn it into a pluripotent stem cell, as opposed to it developing and becoming differentiated. He has learned a technique, and he's won many awards for this discovery, and he can return it. So the part of including this is that there's exciting frontiers out there. I like to compare this to nuclear power, that a lot of times there's a lot of potential out there, but there's a lot of danger that's associated with it. If we can harvest the potential benefits without causing a lot of the damage, then we're in a good situation. But we have to be careful with playing around with stem cells that have a lot of potential, because there can be problems that occur. And then there are adult stem cells, and that's what we typically use in clinical medicine. That's what I use in sports medicine, and that's what most of the doctors that use when we are using stem cells. These are adult stem cells. They can differentiate into total different cells, but they cannot differentiate into an organism. So pluripotent stem cells, as mentioned, they can differentiate into a whole living multicellular organism. These are embryonic stem cells or induced pluripotent stem cells. They are political and ethical issues surrounding their use, so they are not used in clinical situations as of right now. They are extremely expensive. They can cause some terrible cancers too. And there's a rejection potential. So you know when someone gets a kidney or gets a blood transfusion, the body's able to identify whether there are matches or not matches. Same thing with pluripotent stem cells, so they cannot be used ubiquitously in every organism. Where do we get adult stem cells, the ones that we use in the clinical setting? As mentioned, we have autologous and allogenic. And to remind you, autologous means coming from the same person and implanting them back in the same person. Allogenic means coming from another living human and implanting them back into a human. We prefer autologous, mainly because there has been no adverse reactions, no allergic reactions, and there's it's actually less expensive because we're taking something from the same person, concentrating it and implanting it. And our stem cells have two different lineages. There's the hematopoietic, which means blood cells. These are things that you might hear with people with leukemia. We're able to take stem cells, and when people have transplants of stem cells, these are people that have some leukemias and lymphomas. And then what we use in the musculoskeletal system in sports medicine are mesenchymal stem cells. Autologous stem cells come from 4 sources. First, there is cord blood. These are what happen when a baby is born. You may know if you've had a child recently, they're often asked, do you want to save the cord blood? That cord blood is embryologic stem cells. So it's a very powerful but can be very dangerous stem cell. And then it has its limitations to it. There's cord tissue, also has embryonic stem cells. And then what we use in the clinical setting, adult stem cells, they are gotten to us from bone marrow, and that's adult mesenchymal stem cells, or adipose tissue. Me as an orthopedic surgeon, I'm most accustomed to working around the bones, so I get stem cells for my patients from their bone marrow. Plastic surgeons often are more comfortable working around adipose tissue, like liposuction, so they get some potent stem cells from adipose tissues. Mesenchymal stem cells, as we mentioned, and just to reiterate that adult stem cells can either be mesenchymal, which can turn into muscle, tendons, bones, etc., whereas hematopoietic turn into different types of blood cells. Mesenchymal stem cells can differentiate into osteocytes, which are bone cells, chondrocytes, which are cartilage cells, tenocytes, which are tendon cells, synoviocytes, which produce synovium, and a number of other ones, but those are the major ones. Stem cells, we use them to heal tissues and living organisms. So even without implanting them, our body uses the stem cells. They come from our own natural bone marrow, and that's why young people with very healthy bone marrow heal better, because they have a lot of stem cells within their bone marrow, and they have these stem cells that can then migrate to the areas of injury and help healing. As a living organism ages, however, the number of stem cells diminishes, the health of the stem cells diminish, and the ability to heal diminishes. Stem cells here are their beneficial effects. They have a low immunoreactivity, meaning if you implant them, they do not cause a big inflammatory response. Second, they are highly immunosuppressive, meaning if someone's inflamed, that it will cause a decrease inflammation. So these are all beneficial effects, like in arthritis and like in people that have chronic tendinitis. So we don't cause an adverse reaction, immunoreactivity, and we help diminish the amount of inflammation and pain by being immunosuppressive. This is such an interest that right now there are over 500 National Institute of Health studies that are studying stem cells in the musculoskeletal system, the cardiovascular system, the neurologic system, and the oncologic system. Musculoskeletal applications we're using them for now, they help by using stem cells and transferring them to the place of healing. They help bones heal faster. They enhance ligament healing. They enhance tendon healing. And they enhance cartilage healing and regrowth. They enhance meniscal healing, and they enhance skeletal muscle healing. And I would like to make a statement right now, because I think people think adult mesenchymal stem cells are very powerful, meaning if you have arthritis and you inject it into an arthritic knee, that there's all of a sudden new cartilage grows onto the cells. That has not been shown to proven in human beings. It does happen in lower organisms like mice and sheep when they do it, but it does not happen in human beings. What it does is make those cells healthier. So the rate of degradation diminishes, and then pain diminishes also, because it helps lower the inflammatory reaction. And what we know, quite honestly, not enough. Even though I've been doing this for about 13 years, and people in Europe have been doing it a little bit longer, we are studying this, but it's quite honestly in its infancy. And we know there's great promise. We have technologies that help expand it, so you can take a cell and make that cell reproduce itself. So that has a great potential that you can get just a few mesenchymal stem cells, and a laboratory will then multiply them and make them into multiple ones. And there's very low complication rate, because they are, quite honestly, as we mentioned, autologous or self-made, and we just concentrate them and inject them into the site of injury. There are also currently 399 clinical musculoskeletal studies in the works in the United States. So there's a high interest in this, and I hope more information comes out in a rapid manner, as it has been. So mesenchymal stem cells hold great promise for regenerative therapies in musculoskeletal systems. These are reviews that I am looking at. So I'm trying to take not just giving one study, but the studies that I like to show you are called meta-analysis, or they're an analysis of a whole bunch of studies. And reporting of mesenchymal stem cells, preparation protocols, and composition, this really just tells us that all existing clinical studies evaluating mesenchymal stem cell for orthopedics or sports medicine are limited by the inadequate reporting of both preparation protocols and composition. There are deficiencies in reporting of the variables that may officially influence the outcome and preclude interpretation, prevents others from reproducing experimental conditions, and make comparisons across studies difficult. And so they are encouraging the adoption of the emerging minimum reporting standards for clinical studies evaluating the use of mesenchymal stem cells in orthopedics. And in a word, there's not enough standardization. So it's hard for us to really come to conclusions unless the scientists start to use universal preparation techniques. So in summary, for stem cells, they've been proven to aid in bone grafting, revitalizing poorly vascularized bone. These are situations in which people have avascular necrosis or other entities like osteochondritis dissecans. It helps cartilage repair itself. It helps tendons and ligaments repair, and it diminishes the significance of the pain and the degradation in osteoarthritis. And our third topic today is amniotic tissue. So we'll touch on this. This is, first and foremost, remember when we talked about autologous and allogenic. So this is an allogenic, meaning we take something from one location and another human origin and inject it into another human being. So this is what amniotic tissue is. We get it from a multi-layer tissue forming in the innermost layer of the amniotic sac that surrounds the developing fetus. So there's no ethical issues with this. This comes from the placenta, and the placenta or the afterbirth, and that's where people donate the placenta, and companies will then harvest layers of that placenta that have a high level of mesenchymal stem cells. Amniotic stem cells that are harvested have a high level, very high level of stem cells that are in them, and they do not have a rejection potential. So they have a great potential. However, in order for us to take it from the donated amniotic stem cells and get it ready and prepare it to someone else, the companies that do that have to follow FDA regulations. And this gets to be a tricky subject because the FDA does not let you manipulate materials. So you're allowed to transfer tissue. So you can transfer a kidney from one person to another. You can transfer tendons from one donated person to another without much regulation. But you cannot manipulate that product. You cannot manipulate that tissue. As soon as you do, it's considered a drug, and it has to go through a huge number of trials and a huge number of testing. So in order to avoid that, when they take the amniotic fluid, it is freeze-dried, but they're not allowed to test afterwards how many stem cells that are living when it's reconstituted. So you bring it into your office, you bring it into your operating room, and you reconstitute it with saline. Well, we're not permitted to test how much stem cells are in it. So it's variable. We do not know that. So even though amniotic fluid has a high potential, there's a variable there that we don't know the answer to, is how potent they are. So they are safe. I mentioned here they are non-tumorogenic, and non-tumorogenic means they do not cause tumors. Remember, I told you embryonic stem cells, which are like cord blood or induced pluripotent stem cells, can cause tumors. They are non-immunogenic, meaning they do not cause an allergic reaction. So some people get chemicals or medicines like antibiotics, and they'll get an immune reaction to it. Amniotic tissue does not do that. They are actually antimicrobial. So if you're worried about injecting these into an area, and you're worried about an infection, we know that they actually, different than cortisone or steroid injections, they lower your ability to fight infection. These actually heighten your body's ability to fight infection, and they are anti-inflammatory. So there's abundance of positive effects from amniotic fluid, even if we don't know how many stem cells that are in there. So amniotic tissue has growth factors. So let alone, you don't have to worry about the stem cells, which have a potential. The growth factors are very positive for tissue healing, and we know for sure they are osteogenic, meaning they help produce bone. They are chondrogenic, they help heal and produce cartilage. They stimulate tendon and ligament repair, and they prevent adhesions. We've been using amniotic tissue for a long time when nerves are cut, and the neurosurgeon has to sew the nerves together, and they help line it with, they help put an amniotic tissue around it in order to prevent it from adhering and help aid in healing. And the potential benefits have not been proven in a lot of high quality studies. Again, as you can see here, a lot of the biologic tissues, we have some good studies, but we say there are a lot of it's anecdotal, and they are safe, but they can be expensive. So in summary, for the three topics that I talked about, first, there's platelet-rich plasma. There's some strong basic science and clinical evidence that it helps in mild to moderate osteoarthritis and symptoms improvement. There's some good clinical evidence that it helps out with tendinitis and tendinosis, but there are some contradictory reports on that. Stem cell have the highest potential for healing, but we have few high-quality studies that tell us exactly how to prepare it and how to deliver it, and to have a unified statement saying how much they can help out. And there are large variations in the way they are prepared, so we cannot compare one study versus another study. Amniotic tissue has good potential for healing and helps prevent adhesions when we're trying to repair tendons and nerves. There's better long-term studies. We need better long-term studies to verify these things. Amniotic fluid is safe, and there is no harvesting risk. Like when I do bone marrow aspirations, I have to make an incision and take bone marrow out of your pelvis. And then the number of stem cells is a variable, and they are more expensive than taking your own stem cells. And that's the end of my presentation here today. So I'd like to open this up for questions that I hope I'll be able to answer. If I'm not able to answer them, I will research them for you if you like. So I have a few studies here, a few questions, I'm sorry. Does my age have anything to do with my case of osteoarthritis? So I am interpreting that will any of these products help out with osteoarthritis because of an advanced age? It is not really based on age, which I like to call that chronologic age, right? It's more based on biologic age, meaning you can be a 50-year-old person with advanced osteoarthritis. It happens all the time. Biologic materials don't help out once you get to the advanced stage. It's kind of like that ship has sailed. And so if you're 50 with advanced arthritis or you're 90 with advanced arthritis, it does not help. These products don't help you out. If you are 90 and you have mild to moderate osteoarthritis, then it helps you out. So it does not really have a lot to do with aging. Now, the aging can have a factor in this, and the fact that if we are using autologous products, so say we're using platelet-rich plasma from you, and you're 90, and I'm going to prepare them. We have ways around that. We have special centrifuges that are a little bit more expensive that help use spectrophotometry, that help actually have a little higher blood volume that we take from somebody, and we are able to help increase the number of platelets for somebody that is either aging or has a problem with their a low platelet count called thrombocytopenia. So I hope that answers your question. The next question, would orthobiologics be an option for plantar fasciitis? Yes, it is commonly used. I've talked to my foot and ankle doctor that works with me. I've read many articles, and I've talked to a number of podiatrists that feel that it falls into the classification of why this would help out. Different than a steroid that's injected. That's called a catabolic steroid. It actually lowers inflammation, but it breaks down materials. Platelet-rich plasma and stem cells are anabolic anti-inflammatory chemicals. So they have both factors that help out. And the dangers of cortisone that help lower your ability to fight infection and lower your healing rate, where these orthobiologics will help out. And plantar fasciitis is that. It's where the attachment of the plantar fascia is onto the bone becomes overused and it has trouble healing. So it's had a lot of beneficial effects in plantar fasciitis. Can I get a PRP injection before or after surgery? So this is a very good question. That is a matter of debate. As you may see a lot, what I talk about is all the studies out there are very variable. There are studies, and I'm going to give you an example because I do a lot of rotator cuff. Platelet-rich plasma, there are many studies out there that say it helps out. So after you do a rotator cuff repair, you prepare the platelet-rich plasma. We talk about activating or not activating. You often activate it because you want it to clot rapidly because you don't want it to move around after you fix the rotator cuff. So you plant it under the rotator cuff, you heal the rotator cuff. It's a clot of platelet-rich plasma. The majority of studies say it does benefit. The real people it benefits are people in the older age group. If you have a 50-year-old person, it probably doesn't give a huge benefit, but if you have a 70-year-old person, we probably help increase because the potential for that 70-year-old person to heal their rotator cuff diminishes for you. So that's the example I give you there. Because there are so many different types of surgery, this question is very broad. So also platelet-rich plasma after surgery can be helpful because, as I mentioned, different than cortisone, I'm using the example again, rotator cuffs, because I do a lot of rotator cuffs, so if you inject somebody after surgery and they're having trouble recovering because they're inflamed and in pain, you can't do a cortisone injection because you just repaired a tendon and then you give a cortisone to lower their pain level. It will help, it diminishes the healing potential. So people after surgery can get a platelet-rich plasma. And as you may recall in my study, platelet-rich plasma is also antimicrobial, meaning it actually helps fight infection. So all those things that we worry about injecting somebody right after surgery or during surgery because of risk of infection or lowering healing potential are negated when you use platelet-rich plasma. So it can be both used before or during, but you just have to watch because currently no insurance is covering those. So if they are done in either of those time groups, I do not know of any insurance company now that is covering that except for sometimes in injury situations where the lawyer achieves that. So it can be expensive if you decide to do it, but I think the potential is there, and I think most of the studies have shown benefits. And the third question I have here, if I have knee arthritis, can I do a steroid injection and a PRP injection together? No great answer for that, but I think most people do not agree on doing that. They have opposite effects. Cortisone as I mentioned, is a catabolic steroid. So catabolic means breakdown. It breaks down inflammation, so it lowers pain, but it also breaks down proteins. So if you're trying to achieve lower inflammation and healing, then you're probably diminishing the effect of the platelet-rich plasma. So I would not do both together, and I would do them separately. I hope those answered your questions, and I don't know if there are any other questions. Okay. Yeah, thank you. So I'd like to, at this time, I'd like to thank you for all your, for your attention on this evening. And if you have questions, this is my email address, or my websites to talk about Psychobiologics, and there's my email address, and that is actually my cell phone number if you have questions or concerns about platelet-rich plasma. So I'd like to hear from you. Thank you very much.